The AFIB show brings you stories, interviews, lifestyle coaching, and information meant entirely for those with atrial fibrillation, atrial flutter, troublesome ectopic beats, or other heart rhythm disturbances.
Always do it on my own, so I gotta get through it. And the only thing I know is to love what I'm doing. Never give up, never slow, till I finally prove it. Never listen to the no's, I just wanna keep moving. Keep my head up when I act, head up, that's a fact. Never looking back, I'ma keep myself on track. Keep my head up, staying strong, always moving on. Feel I don't belong, tell my thoughts to move along. Push myself to be the best, die with no regrets. Live with every breath, see my message start to spread. And I had so many dreams, when you hit your teens. Life ain't really what it seems, try to find out what it means. Always do it on my own, so I gotta get through it. And the only thing I know is to love what I'm doing. Never give up, never slow, till I finally prove it. Never listen to the no's, I just wanna keep moving. Yeah, I put out all this art, it's my only medicine. Yeah, everything I do, I'm just being genuine. Yeah, I'm sick of being screwed, feel my own adrenaline. Yeah, I do just what I do, and I hope you let me in, yeah.
Okay, AFIBers, it's time. Let's go live with Big Northern Bear.
I'm grateful, oh yeah, able, oh yeah, I'm stable, oh yeah, no label, oh yeah, you know me, I have only a path, I'm lonely, but damn, I'm going to it. I want no fake love, I want the real stuff. Everybody listen up, cause I'll only say
Hey everyone, good evening. Hope you're all doing well tonight. I'm dealing with a bit of an echo here, testing out some new software, so I don't know how well it's going to go. Maybe that didn't quite kill it. I might be the only one who hears the echo. Let me test. I guess the echo is just for me. How's it going, everyone? Happy Canada Day in the U.S. Your 4th of July is coming up, or 2 holidays kind of cross over sometime. I'm testing this new studio, and so I'm bumbling through all this software that I haven't tried before, but I'm hoping I can bring things up to, try a few things, keep switching it up, right? So let's just get organized. You can see I've got the transparent background, and if you say something in chat, it should appear right on the screen. So the whole conversation in chat. So thanks, Lisa. Thanks for that. No echo. That's great. Let me type a little something here. Let's see. Yeah, there it is, Lisa. No echo. Thanks. So there's a bit of a timing difference from when you chat before it'll come on the screen. But we're just messing around tonight. It's a long weekend here in Canada, and I thought I'd get on and wish you all a great long weekend. And I was thinking about a few times people have asked me about when I was a psychiatric nurse. So I thought I'd talk about how can I tie that into heart conditions and make it relevant to my channel. And I think there's a few things I can talk about. So first of all, before I get into that, tomorrow I'm running a 5K for Canada Day. And so Steve Champion, just like I said night before, I'm going to try one of your LMNT electrolyte mix with the salts. So I'm trying the orange. Haven't tried it yet. So this is my honest react. I tried the watermelon before. It was just way too salty, but we'll try the orange. It's not bad, actually. The orange works well with it. It is really salty, but the orange works well with it. So I like to have a big dose of salt the night before a hot race day. Tomorrow should be hot and muggy for the 5K. So I'd like some salt because I don't like to drink during the exercise. I prefer I wake up, I don't drink, might have one coffee 2 hours before. I don't like feeling like I might need the bathroom. And I don't like carrying water or drinking water during just a 5K. Even a 10K, I wouldn't drink on a 10K race. So I like to salt load with some water the day before and just makes the body just hold on to the water you have a little better. So that's the strategy. Okay, it's really weird adjusting to this software, but let's see. I want to talk about, every time we talk about cardioversions, I think about when I used to work at the North Bay Psychiatric Hospital, and we used to do an electro convulsive therapy. And I know they're very different things, but I always think it's like a cardioversion on the brain. But let me take you back here. So I'm going to flip over. You like that little transition? That's kind of cool. So this is one of the only pictures I could find of the old North Bay Psychiatric Hospital because it is level to the ground now. This site is, everything that was there was gone, but this was a fairly isolated psychiatric facility. We had psychogeriatrics, both male and female. We had 2 acute. So acute wards are where someone came in and they'd been living in the community, but perhaps they stopped taking their medication or they got in trouble with the law and the jail wasn't equipped to deal with them due to their psychiatric condition. So they would bring them to the North Bay Psychiatric Hospital. Probably 80% of my shifts I worked were on one of the 2 acute wards. And I believe that was A1 and A. Anyway, there was basically 5 wings. So we had the acute, which was like I just described. We had the chronics. So these were patients that were basically going to live in the psychiatric hospital. They just basically lived there. And quite often they were quite low functioning in terms of how smart they were. Just, I want to say it in a nice way, but some were functioning maybe what you'd consider a 7-year-old, some at a 3-year-old, some at a 12-year-old. And then a lot of them had functioned okay, but they had ongoing issues with either psychosis or hallucinations or schizophrenia, and they were just not able to function anywhere else. And typically, if they were on a chronic instead of a community home, it's because every now and then they had a tendency to just pop you in the nose or just start a fight. That's why they would end up at a more secure facility than a community home. And we had psychogeriatrics, and quite often it was the same thing, but these people were just older, quite often dealt with dementia. And perhaps they were in the old age home and they took a swat at one of the nurses in the old age home. They'd end up at the psychiatric hospital. So my advice is, if you ever end up in an old age home, whatever you do, do not physically threaten the staff, because you don't want to be spending those years in a psychiatric facility. So, but that's the way it was then. If you were like an annoying patient and then one day you just popped off and you punched one of your caregivers, you'd end up in the psych. While you're in the psych, they discharge you from the care home. So you didn't have a care home to go back to. So that would happen quite a bit. Anyway, a bit off topic there. So, and then we had a forensics ward. And a forensics ward, it was actually technically a medium security prison. So it was co-managed by the Ministry of Health and the Ministry of Corrections. And it was a medium security forensic prison. And so I worked some shifts there, and you would think that'd be the most dangerous ward. Was actually one of the safest wards because, first, the patients didn't have a right to refuse medication. They were all properly medicated with no right to refuse, because to end up in the forensics ward, you had to have been found. It's this nebulous. You're guilty of the crime, but in Canada, you're not liable by reason of mental defect. So I know you see courtroom dramas where, oh, temporary insanity, whatever, the person gets off. That's not the case in Canada. Quite often, if you're found not guilty due to mental defect, you'll actually spend more years in a psychiatric forensic facility than you would if you just served the time for the crime. Because the criteria to discharge you at the end of your sentence is normally you've done your years, you've had good behavior, you participated in parole, probation. Whereas psychiatric hospital, the criteria is that the doctor and a board that sits and meets every now and then have decided you're no longer a danger to the community, and that could be never. That could be never. So some of those guys are just always going to be there. And at some point, they'd be there long enough, they would get discharged from there to the psychogeriatric with the other old patients. So it's kind of sad. There's people who spend their whole lives in this hospital that I'm showing on the screen now. And I'm sorry that it's such a poor picture. Let me see if I can zoom in a bit. But the you can't quite make it out, but it was like 5 wings stacked with an intersecting hallway that went up the middle. And it had its own, that big smokestack, we had its own power generation station. So they didn't rely on power from the town. They generated their own power. The front here, this was the original psych facility way back when, and it turned into an administration building. And the North Bay Psychiatric Hospital actually had a catchment area of about 1,200 miles. It was just huge. Patients would come in an 11-hour car ride from way up northern Ontario to be brought here for care. So, one thing we did at the North Bay Psychiatric Hospital, we were one of the last hospitals in the province. Possibly, I don't even know if it's done anymore in Ontario, but to do electroconvulsive therapy, which I'll get into. During my time at the hospital, I participated a lot in 2 types of codes. And if you're ever in the hospital, you hear code yellow, code orange. You'll hear these called over the intercom, code blue, code white. Now, these aren't as standardized as we'd like to think. Code yellow at the psychiatric hospital, it meant we had a missing patient, and it would mean a search. Code red was fire, so you'd go into the fire drill, what you've drilled on in your fire drill. Code white was a violent patient or a risk of violence, risk of immediate violence. So code whites and code blues were the second most common, but code whites were by far the most common. Some nights you'd have 3, 4, 5 code whites over the midnight shift. It would just happen again. It was like, oh my God. And believe it or not, it usually happened coinciding with the time of the full moon. So make of that what you will, but code white, code white, code white. Those were long nights. And the shifts we worked were 12-hour shifts. So you do 12 hours during the day if you did the day shift, or you did a 12-hour night shift. So you'd work like 3, and then you get 2 off, and then you work 2, and you get 3 off, and that's kind of how they rolled. And then after 2 weeks, they flip you. So in the psych hospital, so anyway, back full circle. So when I got my cardioversion, and I've watched some films of cardioversion, it always sort of brought me back to electroconvulsive therapy at the psych. Because like I said, we were one of the few hospitals to do it. So I found this video here showing basically electroconvulsive therapy is not what people think. I mean, you think of shock therapy, it almost seems like it's a torture, right? Like we're torturing the person. It seems cruel and inhumane, like we're torturing someone, but it has a lot in common with a cardioversion of the heart because, first of all, the patient is put under anesthetic. So they're unconscious during the treatment. And I believe they even use the same drug to do it. The second thing is that, usually in a cardioversion, they give you something for pain. Well, the goal of an electroconvulsive therapy is to induce seizures. I'm not quite sure if that's the goal, but that's the effect. And the goal is to pass electricity through certain parts of the brain. And however they came up with this as a treatment, and the first person to be tested on was either pretty brave or pretty unwilling. But it's actually can be highly effective for some people. So they would, like cardiac ablation, they would knock you out and give you a painkiller. For ECT, they would knock someone out and they would give them a muscle relaxant because quite often the seizures and the muscle contractions were quite strong. So without the muscle relaxant, the person might catch their arm on the side of the bed or pull a muscle or something like this, right? So, okay, so I just want to show you here, and I've got the volume off because I'm worried about copyright strikes on YouTube with their automated system. But basically, here's what's going on, and I used to attend these. So they would take this person, and he's fully under at this point. Pausing the video, he's fully under. So they've got the wet towel over his forehead, and I like this video because it's exactly the way that I saw it done. There's other versions of this, but this is the version that they would use. So yeah, so the person's unconscious, is being monitored. You can see they're checking his heart on the background. They're putting the electrodes over the wet cloth. He's got something in his mouth to keep his tongue out of the way of his teeth and to keep him from biting down. And let's see here. It looks like they're charging the machine. Doesn't it seem a lot like a cardioversion? You can see. Let's watch here. And it's just a little like shimmy, right? So when I saw this done, they would kind of repeat that depending on what the prescription was and what they knew the patient's history and how they responded to this, right? So let's. I'm just going to let this play out while I talk. Yeah, he's having more treatments now. So they let the electricity flow, and and then when he's done, they disconnect it all. They stop the anesthesia. The patient comes to, and he's monitored, and he could possibly just go home the same day. Now, they're obviously giving some oxygen. He's not quite out of it yet. So now, ECT, far from being, the way the movies make it look, I've actually seen patients that were so depressed, like just so damn depressed, that they couldn't function, and their family couldn't even relate to them, and they were just in the hospital and suicidal and tried this drug and that drug, and they would need constant monitoring on suicide watch. And then ECT in Ontario had to be the last resort. So that means they'd had to try everything before they could recommend it to you. The other thing is that even on the forensics ward, ECT could not be compelled. No court could compel you to participate in ECT. If you had a guardian appointed for you as your decision maker, they could not consent to an ECT no matter how sick you were. It was always up to the patient. It was a very special part of the law. So it was always with the patient agreement. Well, I've seen ECT just do amazing things. People who have just been depressed and sad for so long and just unable to participate in life and unable to just trying to kill themselves, so depressed. Suddenly you walk in the next morning and they're smiling and laughing with the other patients, and you're like, oh my God, what happened? Oh yeah, they went for ECT. The ECT is starting to work. So they would have this treatment about once a week. They maybe need 3 times, 6 times, 2 times. It kind of varied. And they could be discharged. It was an amazing thing. Now, I've heard of ECTs being used for other things, but you can think of it as a bit of a brain reset. And I believe they use far less current than they use in like a cardioversion of the heart, but it's a bit of a brain reset. So electricity is a drug, right? We know that as AFib patients, they can shock our heart and set it back to normal. Well, something similar can happen with the brain. And I actually have a cousin who had a true brain ablation as a new procedure. I'd love to have them on the channel sometime. They can talk about that. But it's very experimental. He's one of the first people in the world to get it. So, and he used that actually to end his tremors in his hands. He got use of his hands back. So, electricity, ablations, cardioversions, electroconvulsive therapy. I mean, these are definitely forms of treatment that aren't discussed a lot, especially ECTs. Not discussed a lot. It's not understood. Unless you've seen it in person or seen a video like this, I mean, you can tell it's really not. Anyone who's been through a cardioversion for AFib will recognize this scene and realize that it's actually, once you've been through it, it's not that bad. It's just like that for ECT. So, a couple more ECT videos here. This is another method I saw. Let me see if I can find the scene. Go back to the screen share. So they're actually placing and taping electrodes to his skin. So this is not how we did it at the North Bay Hospital. Seems to be a different setup and possibly treating for something different. In North Bay, it was pretty much always for depression with suicidal ideation. Pretty much. I think some patients with psychosis were treated this way, and it was helpful, but it was mostly for patients with intractable depression, right? So anyway, back to codes at the hospital. I'm really wandering tonight, but one of the codes I would go on a lot is the code white. So the code white, and there's a cute little video here that's staged by some nursing staff. And I'm going to play like 30 seconds of it, and I hope I don't get some kind of copyright strike, but let's just listen here. Okay, so there's a lot going on in this scene for those who haven't been trained. But here we have a patient who is escalating. So they are not violent, but they're clearly getting more and more upset. And then we have 2 nurses. We have one nurse who's waiting calmly just outside the door. Now, the goal for this nurse is that she wants to be seen. She wants to be, just so you know I'm here. But she's not making eye contact because the conversation is between the primary nurse and the patient. So she's not making eye contact. She's trying to be non-threatening. You can see she's standing in a very non-threatening pose, and she's being non-confrontational, but she's here. Her job is to keep an eye on the primary nurse and make sure the primary nurse is safe, which is this gentleman here by the door. Now, his job is he's not blocking the exit, because you don't want to corner someone who explodes. So you don't want them to feel trapped. The goal right now is to de-escalate this person, to make them feel heard, to make them feel understood. Now, behind the scenes, I'm sure there's, behind this door down the hall, they're on the phone calling other staff for a quiet code white. They're phoning the wards. Can you send someone? Can you send someone? And those people will all be waiting up at the nursing station. So should all hell break loose in this room, within about 5 seconds, there'll be 4 or 5 trained restraint nurses in this room. But this all is out of sight, because if we can de-escalate the patient, we will. And so one of the goals is to de-escalate them. And if there's a PRN prescribed, which means it's a medication you give as needed. That's what PRN means. So the doctor might prescribe something like Haldol or some sort of, there's drugs that are categorized as chemical restraints because they'll actually cause a violent patient just to want to go to sleep, or just cause them to lose all energy, right? Or they might just describe a bigger dose of the meds they're already on, like a bolus, just to bring them back down. So here we have the primary nurse, and let's just listen to him for a minute. He's letting her go, letting her express. So they're actually putting on the screen verbal de-escalate. So this is obviously their little training procedure. Decide if patient is appropriate for verbal de-escalation. Patients responding, engage in conversation, not an active threat to safety. Now this last one, how can you ever know? How can you ever know? Because it can happen fast. I would say they're an active threat right now. I would consider that a potential threat right now, especially if the patient hasn't been searched yet. So, maybe I'm a little old school. So I'm going to jump through the video a bit, because I don't think this video they actually get to where the patient, even when he's standing at the door. So at this point, he's probably a little concerned about how agitated she's get, because now you can see there's a second person in the hallway, and he's at the exit now. So he's not blocking the door, but he wants to be able to exit if he needs to. Okay. Oh, there's another person in there. They must have crept in when we jumped through. So they're actually staging for potential takedown. Okay. So patient is showing cues of lashing out. Hold your hands out and open with your palms up. This gestures that you are not a threat. Yeah, that's a good strategy. It also protects your face if you need to. So, and bad acting aside, at this point, when you see that rage in the face, you don't know how it's going to go. In fact, it's literally 50-50 at this point. It's literally 50-50 that you're going to get some fingernails across your face at this point. Let's jump to the end here. So they've got her sitting. So once she's sitting, that used to be our cue that we could move into the room, because usually get them to sit because they've agreed to take their medication. So that's how that would be our cue that more people could move into the room. Yeah, and here they come. So the primary nurse got down to her level, and that's another thing we used to do. Squat down to her level and talk to her. Remember, these patients, they still have dignity, and you have to treat them with dignity and with respect, despite the fact that you might be in danger right now. I mean, you're a nurse, not a cop, okay? And imagine some cops treat people with dignity. I don't know, but as a nurse, you're supposed to do that. So I believe, yeah. So they get her to take her IM, which is an intramuscular injection, and it's probably a happy ending. Yeah, now we're going back to classroom. But I found this other video that was actually filmed overseas somewhere, but it gives you an idea what a mild outbreak would look like. Calling for haloperidol. So that's a chemical restraint, right? So So the way we used to do it, you see how they have one guy gripping the shoulder, one guy gripping the arm, and a guy on each leg. That is not how we did it. We had one person whose job was to stabilize the patient's head, and then one person on each limb. And if you were assigned the left arm, let's say, your job was to make sure his left arm didn't go punch the guy on the right. And the person managing the right arm, his job was to make sure it didn't go punch the guy on the left. So the person managing the head, your job was to prevent bite wounds and also prevent the patient from injuring themselves. So managing the head was the worst part, because you got to use just a minimal amount of pressure to prevent them from hurting themselves. But if they're fighting against you, they can really damage their neck. So we can see this is an ineffective restraint. I mean, this guy's easily to move around, even though it's clearly just some acting going on here. He's clearly able to move around. And at this point, if we were giving someone a chemical restraint and they were in bed, there would actually be physical restraints employed. So straps along the wrists would be necessary, unfortunately. So let's jump ahead. Let's see what's going on here. Yeah, so they're just faking where he woke up from his treatment. I've seen this happen where patients tear out an IV, tear off the blood pressure cuff, and they just get up. They've just had enough. They've just had enough. I'm getting out of this bed. This patient is highly agitated. This patient is a danger to himself and others at this point. So she's calling the code white, which is right, and everyone's gathering. So that's the exact right thing. And then we have some really highly dramatic music, and it gets rather bonkers, but it's an entertaining video. It certainly brought me back. So, I mean, a goal of the cold white is the safety of the patient and the staff, to de-escalate, talk them down until you're left no alternative. Okay, and then the doctor will prescribe, might even prescribe two, might say, well, if the patients cooperate, we're going to give them X. If the patient's not cooperating, we'll give them Y as a chemical restraint. And quite often, this is in the middle of the night. Doctor's not even there. So actually, there's an RN on the phone with the doctor getting verbal orders to do this. So that's the code white. The other big code at the psychiatric hospital was code blue. So here's a little code blue training video. I'm just going to let it run with the subtitles, but basically this lady's come in. She's the care nurse for this patient. She's taken the history. The patient stated they haven't been feeling well at all today. She's noticing a drop in blood pressure when she checks the blood pressure. So now the duty nurse comes in, and the first thing to do is give the history, and she does her own assessment, obviously, but we want to get to the action. So now she's calling for a code blue. So rapid response, standard operating procedure. So they're going through this. So this, I don't know how much this has changed over the years, but I'm glad they're using a dummy for this, because when you can't prepare for a code blue CPR, you just can't do it right on a real person, because you can't use the necessary pressure and technique without risk of injury. So you can see the whole team's gathering. There's a doctor, several nurses. At this point, they're skipping through. There's usually standing orders on how to handle this situation, and they're skipping through those. Do this, assess this, react with this. So I want to get to where they're actually doing CPR. So here we are. So they're actually doing CPR. So I was actually a St. John's Ambulance CPR instructor, and I used to recertify nurses on CPR. So you'll notice that the CPR in a hospital is done at a quicker pace than they typically teach you in first aid training. It's more aggressive, it's more exhausting. The staff have to switch out, and I mean, it could go on and on and on. And even though they'll hook you up to the pads, and sometimes these pads can act as an external pacemaker, but you can't pace a heart that isn't beating. So you could be an hour doing this, and it's exhausting, and they'll actually have to take a break sometimes for exhaustion. So, but they're doing everything they can for this patient. They're establishing the airway, circulation, the ABCs, and now they're analyzing. The machine's advising a shock. Now, it wouldn't be the machine advising if there was actually a doctor present, so I believe this is just nursing staff here. But the machines typically only advise a shock if they sense like ventricular fibrillation. They're looking for fibrillation. They're not going to advise a shock if it's just tachycardia or bradycardia. They're actually looking for fibrillation because that's the recommended treatment, I guess. Like VTAC, you wouldn't shock. It's just not the right way to go. You would do that as maybe you're doing that to try and reset them, but it's not the same shock, and it's not delivered with the same energy and the same pulse wave or sine wave on the electrical signal. So I went to several code white or code blues at the psychiatric hospital, but they were all what we termed after the fact precautionary. I was never actually present when we actually had to do CPR on someone. So there was a code blue while I was on duty, but I wasn't on the code blue team that night, and the patient didn't make it. And that was a sad thing because they were a long-term patient that everyone liked. Anyway, I don't have much more to talk about, but I just wanted to share some of this from my past and just get on and interact if anyone was out there. And if not, it's okay. It's a long weekend here, and I think the U.S. has their long weekend, so it's okay. Anyway, and try out the new studio. So we got some like new special effects going on here. You know, the chat widget showing up. Little moose. I like the little moose in the background. It's kind of cool. And I think that's it. I'm going to wish you all a great weekend and play us out.
It's tragic, we're not all elastic, but maybe there's magic. Believe you could have it, and I know of sadness, the anxious and panic, the infinite vastness of all